Hello and welcome to our webinar series, the Green Bag Lunch Green Tea webinar series. Today's topic is food as medicine. And while we're waiting for people to log on, we'll go through a few housekeeping items. So first of all, this webinar platform works best when using Chrome. If you're having technical difficulties, the first thing would be to close out your browser, restart the computer, and try to log back in. We're doing this webinar series ongoing at the moment, so feel free to invite colleagues for any upcoming topics. The webinars will fall mostly on the first Monday of every month, with the exception of some holidays. If you have any questions for the presenters, we can record those in the attendee chat room, which is to the left side of your screen. And at the end of the presentation, we'll leave time to answer those. So feel free to record your questions there, and we'll return to it. So we're going to go ahead and start and let people just join on the call as they get here. So let food be thy medicine and medicine be thy food. Hippocrates said this, hard to believe, over 2,000 years ago. We've sort of seemingly lost our way a little bit on the idea that we are what we eat. But certainly when we can look at a person's diet, we can dictate disease states. And we also know that, of course, diet is just one risk factor. We've got physical inactivity now, increasingly is being recognized as increasingly important determinant of health. And this shift toward a more sedentary lifestyle in combination with poor dietary choices has led to quite a prevalence of chronic disease. So, of course, we'll be talking about chronic disease as it relates to dietary and behavior choices. We've known for many years that diet plays a key role as a risk factor for chronic disease. This is now really apparent on a global level due to these changes that have swept the entire world since the second half of the 20th century. Including major modifications in diet, first in industrial regions and more recently in developing countries. Traditional, largely plant-based diets have been replaced by high-fat, energy-dense diets with a substantial emphasis on animal-based foods. So at this point, chronic disease is one of the more pressing health epidemics of our time. But emerging evidence, dietary evidence, is starting to show that we can offer more economical, sustainable, and effective treatments through dietary changes rather than going down the pharmaceutical route. So to put it into perspective, half of all American adults are now living with at least one chronic health conditions, and a quarter have more than one. Rates of obesity are increasing among school-aged children, setting them up for chronic diseases later in life. Obesity and chronic disease tend to go hand in hand, not always, but as a general rule. A quarter of all people living with chronic disease experience one or more daily activity limitations, and that people with chronic diseases report reduced quality of life that affects their livelihoods in one form or another. And 75% of our healthcare expenditures are now being used to treat chronic illness. Some people have said that having a chronic disease is like having a full-time job, but a second full-time job. That is quite a burden on their lifestyle. And historically, heart disease was always the leading cause of death, but this has been slowly in decline, largely in part to advanced technology and life-saving resources within the hospital setting. But we're seeing cancer slowly inching up as a major contributor of death. It has been reported, of course, that only 5 to 10% of cancers are the result of genetic predisposition, which means that we really need to be looking to the remaining 90% coming from environmental or behavioral factors. But we'll need to start really turning our attention to these environmental and behavioral factors, which I'll get into in a later slide. But we all really have a vested interest in improving chronic disease rates for the future, regardless if we're personally impacted by them. Our national financial burden of chronic disease stands at $3 trillion and counting. Corporate and labor sectors will definitely benefit from a more productive and energized workforce due to reduced sick time and absenteeism. And of course, kids who are well nourished during critical developmental periods will have a better chance at avoiding the pitfalls of allergies and disease and experience better academic achievement, which translates into a more viable future workforce. But moreover, we need to look for upstream solutions to the diseases to treating these diseases that are accessible, effective, and within our reach. So the gold standard in the research literature for nutrition recommendations for prevention, cure, and also as a mechanism to improve health outcomes for those who are currently being treated for disease is the plant-based or Mediterranean diet. The Mediterranean diet has been the most proliferatively studied and consistently shows positive results in treating disease. But because there's lingering confusion around plant-based diets, I always find it's helpful to define them more thoroughly. But really, plant-based diets refers to a whole foods dietary approach. It restricts or eliminates refined and processed foods almost entirely, getting most of the daily nutrients from fruits, vegetables, healthy oils, nuts, and other plant-based proteins. This diet obviously significantly limits animal proteins, meat, dairy, eggs, and so on. The Mediterranean diet is plant-based, but with minimal intake of dairy, fish, poultry, and even red meat. But the large emphasis is on nuts and olive oil or polyunsaturated fats is the key factor. And then, of course, if we're talking a strict plant-based diet, you're thinking a vegan diet. But not all vegans are staying true to a whole foods dietary approach. There's plenty of processed foods out there targeting vegans, and so vegans don't necessarily always have better health outcomes than people who choose to eat animal protein. So that's worth mentioning. But ideally, the ratio of plant-based foods in your diet would be 70 to 75% of your daily nutrients coming from plant-based sources, vegetables, and fruits. So on that note, not all plant-based diets are really created equal. There's a dose-related response with the health benefits, the truer you are towards eating an entirely plant-based diet. And that would include a vegan diet, whole foods diet. But we need to be careful that when we're recommending plant-based diets, people aren't eating more processed foods, thereby mitigating any positive health benefit from the switch. So we really need to emphasize a whole foods dietary approach. And we also need to recognize that in some nutritionally challenged populations, there's a small amount of meat protein is important for growth and development. I just want to comment on this expert researcher, Raja Deer. He's a researcher on the microbiome. He states that the best longevity diets that we know of in the research really do include some small consumption of animal protein, but this would be consistent with having the animal protein be less than 20 to 30% of the overall dietary intake, staying true to that 70% intake of vegetables and fruits. So rather than get into the demonstrating the efficacy of plant-based diets in the research, we really need to start to focus more on the way that food is being produced. And some of the recent literature surrounding organic food consumption does find that there is a reduced risk of overall cancer in high consumers of organic foods. There's suggestive evidence that indicates that organic food consumption also reduces the risk of allergies and overweight and obesity. But we have to be careful because residual confounding is likely, as consumers of organic food also tend to have healthier lifestyles overall. but overall, when we're looking at studies that look at the health implications of organic food, we're finding consistently that they're basically showing the lower risk of childhood allergies, like I said, overweight and obesity, and non-Hodgkin's lymphoma, but not for the total overall cancer with consumers of organic food. And this is a review that emphasized that pesticide exposure from conventional food production constitutes a main health concern, especially as it relates to prenatal exposure to chemicals and neurological impairments. The nutrient density debate is still ongoing. This study found that nutrient composition differs only minimally between organic and conventional crops, with higher contents of phenolic compounds in organic fruits and vegetables. But of greater concern is this prevalent use of antibiotics in conventional animal production as a key driver in antibiotic resistance in society. But the study surmised that organic food production has several documented and potential benefits for improving human health, and a wider application of these methods would therefore likely benefit human health overall. So obviously, there's many ways we can start to shift our health care culture, whereby we can give food priority as a top line treatment to disease. And one example is with food prescriptions. And our guest today, Dr. Rita Nguyen, will elaborate on this. But I just wanted to highlight a few points from an article that from March of last year about a study that was conducted on subsidizing um, fruits and vegetables in Medicare and Medicaid. And they gave 30% subsidy on fruits and vegetables, like a fruits and vegetables incentive, and a 30% subsidy on several other foods, including whole grains, nuts, seeds, seafood, and plant oils. And over the lifetime, the study suggests that the fruit and vegetable incentive would prevent 1.93 million cardiovascular diseases and 0.35 million cardiovascular deaths, saving about 40 billion in healthcare costs. So a healthy food incentive really could prevent substantial amounts of cardiovascular disease. And in the US right now, there's a new $25 million produce prescription program that was just passed in the 2018 Farm Bill, which would provide funding to support pilot projects over the next 5 years. So with that, I would love to introduce Dr. Rita Nguyen. Dr. Rita is an assistant health officer for the San Francisco Department of Public Health Population Health Division, who also serves as the chronic disease physician specialist. In this role, she supports and provides thought leadership to chronic disease prevention efforts for the city and county of San Francisco. This includes supporting community-based initiatives, working collaboratively with health systems to advance population health, and informing efforts that promote policy, systems, and environmental changes that support health. But more relevant to our webinar today, she leads the Food is Medicine Collaborative in San Francisco, which is a multi-sector collaboration that advances system change in healthcare to address food insecurity and promote nutritional behavior change in underserved patients' populations. She's a practicing hospitalist at Zuckerberg San Francisco General Hospital, and she's an assistant clinical professor at UCSF. So welcome to Dr. Nguyen. We look forward to hearing from you.
Great. Thank you, Meg. And thank you, everybody, for your interest in this topic. And thanks again for that overview of the connection between diet and chronic disease, which is certainly a passion area for me as well. I know that on the phone we have practitioners and nurses who see patients, and that's really what brought me to this work, is the frustration that I've had trying to manage chronic disease like hypertension and diabetes. And when my patients come to me and tell me that it stresses them out that I remind them to take their medications and eat well because they can't afford to eat well or they don't live near grocery stores, all I can then say is that's a real shame. Here's another prescription for medication. And that was a little crazy making to me that our healthcare system only had that available. And so that's sort of the source of inspiration for me to pursue this intersection between food and health. And I really like this quote by the author, farmer, and food writer Wendell Berry, that people are fed by the food industry, which pays no attention to health, and are treated by the health industry, which pays no attention. So, by you being here and listening to this talk and engaging in this body of work, I hope that to not be so true. So, I'm going to really take us through the intersection between food and health from the perspective of social justice and equity, and looking particularly at food insecurity. So, those who are most vulnerable to the health implications of having inadequate access to healthy food. And so, for those of you who may not be familiar with the terminology of food insecurity, it's a household measure that's um, defined by the USDA as the lack of consistent, dependable access to enough food for active, healthy living. So it's not just any type of food, but truly active, truly nutritious food that enables active, healthy, along the lines of what Meg was introducing. So about 11% of households in the U.S. are food insecure. And not surprisingly, that burden is borne disproportionately by low income families. So, if we were to look at what it takes to comply by USD recommendations around healthy eating, it would require that a low income family actually spends on the order of 43 to 70% of their food budget on fruits and vegetables. You can already begin to see how difficult it is for low income families to actually be eating healthy. And not surprisingly, but also unfortunately, this burden of food insecurity is also disproportionately borne by communities of color. So you can see that Black, non Hispanic, and Hispanic populations bear the highest front of food insecurity. This also bears out in the health outcomes we see in terms of cardiovascular disease, diabetes, and obesity. So, what is the link between food insecurity and health? And I'm going to go through these research slides fairly quickly so we can get on to talk about interventions that are going on in the US and in other countries, and also time for questions. To answer any questions related to the research I cover. So, what is the link between food insecurity and health? I like this conceptual framework that's been devised by Hilary Seligman, that food insecurity naturally leads to coping strategies where folks will eat foods that are high in calories but low in nutrient quality. And this is just a normal coping mechanism. It is not for laziness or lack of knowledge. This is just a basic human and even animal instinct to cope with food insecurity. And as you can imagine, this lower dietary quality then feeds into worse chronic disease. Once you're already ill, you end up spending more on healthcare expenditures, and you're less employable because of all the time you have off. It also, you may be struck with disabilities related to your chronic diseases. As part of this, your household income then decreases, which then begets even more food insecurity. And so it's sort of this vicious cycle whereby food insecurity leads back to these dietary coping strategies that just perpetuate chronic disease. And we see in the literature that when you look at food insecure populations compared to not to food secure populations, in both children and adults, it's associated with a number of different outcomes. So for kids, certainly poorer health, more hospitalizations, but importantly, behavioral issues and worse school performance, which, as you can imagine, then puts kids on certain trajectories on what their educational income earning potential is in the future if already they're starting off on the bad foot. For adults, we see that there's an increased risk of obesity, diabetes, hypertension, depression, and hospitalization for those who are food secure versus those who are not. And you may just say that this is a problem of poverty, that poverty is the underlying mechanism that drives all of this. But in most studies, they actually control for income. And even if you control for income, if you're same income, but you're food secure versus food insecure, you're still seeing these associations with worse health outcomes. And on the right, you could see one paper that showed the increased likelihood of having chronic illnesses based on the degree of food insecurity you have. There are other studies also that show sort of this dose response, that the more severe your food security, the more likely you are to have chronic disease. And then what's interesting about this study that came out just last year was that those who are food insecure are actually at risk of even developing diabetes. So if they followed folks over, I want to say it was about 10 years, and they found that in Canada that the incidence of developing diabetes was twice that of food secure populations. Um, And Canada is an interesting place to do this study because everyone has healthcare. So you could argue, oh, perhaps these people weren't getting adequate healthcare and then developed diabetes, but that's not the case in Canada. So what is the link between food insecurity and healthcare costs? So we do know that those who are food insecure tend to have more emergency room visits and hospital stays. And when they are in the hospital, they tend to be in the hospital for longer. We also know that in this dose response scenario, we also see that those who are more severely food insecure actually spend more on healthcare costs annually. And again, this was done in Canada where everybody has access to healthcare. So it's not as if people are presenting to healthcare much later. The study was then repeated in the US and it saw similar differences in terms of the annual cost of care. So the highlighted column on the right shows the annualized difference between diabetics who were food secure versus food insecure, and the same for those who were hypertensive versus those who were heart disease. Those with chronic disease certainly were spending more on their health care. And so we know that the two are associated. Being food insecure is associated with worse health outcomes and spending more on health care. But if we intervene and give food, does that actually make a difference? What we are seeing in the literature is that yes, maybe not surprising to a lot of us because it's a little intuitive that eating well would lead to healthier outcomes. But unfortunately, some health insurers do want us to prove that sort of basic fact. And so I summarized in 3 studies. So the first was diabetic boxes at food banks. So they gave diabetic friendly boxes to food pantry recipients and then tracked their A1C control over time. And there was actually a statistically significant decline in hemoglobin A1C amongst those who received diabetic food boxes. They also had on site glucose screening and would plug people into healthcare. There was a pilot that came out of San Francisco, again, a small one where there's only 52 individuals, but they received 6 months of complete nutrition delivered to them. And half were HIV positive, half were diabetic. And we saw that there was improved diabetes control in terms of A1C, but also improved HIV medication adherence. Not statistically significant as the sample size was small, but they're now engaged in an RCT. The gourmet heart failure paper came out just last year, and that looked at patients with congestive heart failure who received 30 days of complete nutrition upon discharge, and there was an improvement in heart failure symptoms. And in terms of their survival curve, there was actually a difference in not survival. It was a survival curve, but based on readmission, that there was a decrease in readmissions for those who actually got the food supplement. There are a lot of other small studies that I haven't included here, many of which haven't made it to the literature, but a lot of pilot programs have been demonstrating improved health outcomes. And one that you all may be familiar with is the Geisinger Food Pharmacy, which also showed a decline in A1C among participants who received food out of their clinical setting. And looking at literature around SNAP benefits, so that's the Supplemental Nutrition Access Program. Um, and this was formerly called food stamps. So children who had access to SNAP followed over the course of their childhood and adulthood showed decreased stunted growth, decreased heart disease, and decreased development of obesity, and a greater chance of completing high school. And this was an interesting study in that SNAP benefits weren't rolled out uniformly across the country. So certain jurisdictions got SNAP before others. And so it was sort of a natural experiment that you could see of those places that got SNAP compared to those who didn't. How did the recipients fare in terms of health and even educational outcomes? We also know that among the elderly who access SNAP, uh, those who get SNAP are less likely to skip needed medications because there's more sort of economic security and folks are able to redirect their funds and just their brain power to other things like making it to appointments and being compliant with medications. And so we have the suggestion that giving food actually helps. Then the question is, does intervening improve healthcare costs? And we are seeing this. I apologize, it's a lot of information at once. The animations don't quite work in the webinar, but there's 2 studies here I'm trying to cover. One is colloquially called the MANA study, done in the Philadelphia region, and another one was done in Massachusetts, where they provided medically tailored meals to Medicaid and Medicare beneficiaries. In the MANA study, they got complete nutrition therapies in the order of 3 to 6 months. And for the Massachusetts study, most folks got food intervention on the order of about 9 months. And in the Massachusetts study, they were getting the equivalent of about 2 meals a day. And then they looked at claims data to figure out what did it cost in terms of healthcare expenditures for those who were receiving this intervention. And you can see that um, from baseline to comparing to a matched control, that there was actually healthcare savings, that those who were receiving the medically tailored meals ended up having reduced costs in healthcare compared to a matched control. So this is looking at a similar um, group of beneficiaries getting Medicaid and or Medicare, matching them on characteristics and then comparing the difference in costs. And the second table is looking specifically at the MANIS study where they teased out the average monthly inpatient costs as well as length of stay when folks were inpatient and then how quickly they were to discharge to home. And you can see that the differences between the folks who receive food versus match control were statistically significant in terms of cost for inpatient, length of stay, and likelihood to discharge home. Going back to SNAP literature, again, we see that those who receive SNAP have less annual healthcare expenses than those who do not receive SNAP. And so now that we've gone through what the link is between food insecurity and health and the cost, and knowing that giving food seems to improve health and healthcare costs, what's happening at the intersection of food and health? And so, as many of you who are healthcare practitioners know, our two worlds do seem very siloed, um, and there's a growing call of action across the country really to merge these two efforts of like how does food systems and food and healthcare systems work together to address this concept of food as a medicine and promote the health of communities. And so one way that I like to think about sort of the spectrum of interventions is to think about on a spectrum of intensity on the far left, what healthcare systems can do to address food insecurity is to screen and navigate to resources. Increasingly, there's a call for healthcare to address social determinants of health and food insecurity being one of the larger drivers of chronic disease, to actually screen for food insecurity with 2 questions. And so if any of you are interested, you can just Google the hunger vital sign. And it asks, in the last 12 months, um, we felt that the money that we had to buy food just didn't last the whole month, or that the food that we bought didn't last and we were worried about how we were going to get more food. If you say either sometimes true or often true to either of those, then you would screen positive for food insecurity. This 2-item screen has been validated against the longer 12 and 16 item screen, and it fares well in terms of sensitivity and specificity. So if you're ever wanting to ask your patients, just Google hunger vital sign. One thing to screen positive and then figure out like, well, what do I do for my patient? How do I refer them to resources? And more ideally, how do I navigate? Because giving folks handouts often isn't adequate to make sure that folks actually connect. You can also think about food programming. So increasingly, healthcare is interested in bringing food to healthcare. And let me see if, I realize the animation here is missing. So the other spectrum, the other aspects of the food programming isn't here. But the next one would, under red, would be bringing food to healthcare, and under blue, it would be bringing healthcare to food. And on the far right, it's thinking about systems change and rearranging healthcare to support food insecurity. So if you break out the bringing food to healthcare interventions in red, some of you are probably familiar with some of this or have seen it in the media around providing nutrition education or food prescription or food vouchers. Folks also have mobile food vans coming to clinics. There's also food pharmacies and teaching kitchens as well as medically tailored meals. And thinking about other food programming that's related to bringing healthcare to food, buyers in terms of nonprofits, but also local vendors and grocers could be offering healthier offerings or providing health screening at food programs. And I've also seen instances where pharma companies will be paying to have either an MD, RN, or RD at a grocery store to help promote health. And then on the far right, thinking about the greater systems and policy change, there's been a lot of movement around this concept of how do we get payers, particularly health insurance, to actually pay for food interventions. And there has been some success in that regard. California right now actually has a $6 million Medicaid pilot providing medically tailored meals to individuals, and I'll speak more to that later. The other way to frame the type of interventions that could exist in this space is along the spectrum of prevention in terms of primary, secondary, and chronic disease management. And that some folks have characterized this as sort of a triangle in terms of those at the tip of the triangle are a relatively smaller group of individuals who already have developed chronic disease versus a population which is at the base of the triangle that may not have already developed the congestive heart failure that would warrant medically tailored meals. But in that case, there's a role for nutrition education, for screening referral, and food vouchers. There's some fluidity within this. You can certainly provide food vouchers and food prescriptions to the most critically ill. But this is another way to think about generally how some folks think about the level of intervention for these different food programming. And so I'll dive in a little bit deeper about food pharmacies, which we have a little bit more experience with in San Francisco as part of the Food as Medicine Collaborative. And so our food pharmacy model is really premised on this 5-pronged comprehensive model that's based at clinical settings where patients are prescribed healthy foods by their provider. We particularly focus on Black African Americans with high blood pressure from an equity perspective. And so on site, they can access the food itself. On-site nutritionists provide knowledge and skills through cooking demonstrations. We also have giveaways because most of our patients are quite low income. And so we'll give out things like crock pots and hot plates for those who don't have kitchens, as well as olive oil and spices and cutting boards and measuring cups. And then making sure that folks are then connected to other food resources in the city. We have been very fortunate in terms of the partnerships that we've been able to develop through food pharmacy, and much credit to Meg and Navitas Organic. We are increasingly being able to control where we are sourcing the foods. Most of the donations comes from the food bank, but it is our long-term vision to be more mindful about how we're sourcing locally and organic to support the environment. And thanks to the partnership with Meg, we've been able to expand to other organic farms as well to provide these greater variety to our patients. And so in terms of outcomes data, we've seen that subjectively patients report increased access to healthier foods, as well as improved healthy eating practices. And there was a statistically significant decline in blood pressure, about 5 millimeters of mercury, which is actually about what you would see with 11 pounds of weight loss or a medication change. One piece of feedback we get very loudly from our patients and community is the positive aspect of having a community when they come to food pharmacy, and that's a lot of what brings them back. And there is something about social connectedness and social cohesion that matters to health, and it is one of the social determinants of health. So I'll spend a few minutes talking about, on the far spectrum, what is our long game here, that although we are now at 10 clinics in San Francisco across 4 health systems with food pharmacy programming, the end all be all isn't that every clinic have food pharmacies necessarily. I do think it would be ideal if healthcare took a stand and was addressing food insecurity and healthy eating in some tangible, more engaging way than we have been in the past. But the long game here is how do we reorient resources to invest in prevention, into diet, into healthy eating. One way that I like to conceptualize this is to think about the way the US currently invests in social services versus healthcare. And so we, as you can see, compared to a lot of other developed, wealthy countries, have sort of this inverted investment in terms of our social services versus health services. And social services are things along anti-poverty measures, welfare, education. And yet we choose to invest in this manner, and our health outcomes are also an outlier. On a variety of different health and quality metrics, we have really abysmal outcomes compared to our other colleagues or other countries that have um, similar wealth. And so this is just life expectancy at birth. And so part of the movement around food as medicine and having healthcare pay for food is a reorientation of how do we reinvest our healthcare dollars into prevention and healthy eating rather than into dialysis and amputation sort of on the other end, and that we're not making smart investments, and what we're paying for, we're not getting as much out of it. And so, moving on to successes and challenges in this movement, um, one success is that it actually works. The data that's coming out is showing that giving food improves health and it decreases healthcare utilization. There's growing interest in the media and policy. There always seems to be a growing crop of articles coming out to support the concept of food as medicine. Both Massachusetts and North Carolina have written into their Medicaid waivers um, a mechanism for Medicaid to pay for food, and we in California are trying to get the same. There's also a number of private insurance companies that have been piloting this concept of paying for food. Um, some of it is upon discharge, some of it is sort of an advertising gimmick to have them seem like a more appealing coverage plan for individuals to get a month or two of delivered meals. We're hoping that it becomes part of the medical loss ratio and that this is actually part of covered benefits ongoing for individuals. And as I'd mentioned previously, healthcare is increasingly interested in social determinants of health. And so there is a growing interest in how does healthcare do this work, whether it be on-site food or making close connections to see community-based organizations to connect their patients to food interventions. And then in terms of challenges, as you may have garnered from what I've um, presented today, there isn't a lot of funding to actually support data and trials for food interventions. And so it's unknown exactly what the dose is. Is it 1 meal a day? Or is it two? Or is it 3 meals a day? Does it have to be home delivered? Does it have to be meals? Or can it be groceries? And what dose of food vouchers or food prescriptions is enough to actually impact someone's health? What's also not known is how long intervention have to go on for before you see sustained change over time. What we've been seeing in some of our data is even with food vouchers on the order of $20 to $40 a month, patients are reporting that they have continued changes in their health, continued changes in their diet even after they stop receiving health. And so the theory behind that is that once folks have access to healthy foods and are trying it, they realize that this is actually something that they can incorporate into their lives and continue to do so even after vouchers end. But there's not enough well controlled trials to let us know exactly what is the optimal dose and frequency. It's also unclear whether or not there's interest in the long term for insurers that the pilots we are seeing funded for typically 3, 6, or 9 months. But then the question becomes how long of investment how can food be viewed as a chronic medication or chronic treatment the way that hypertensive or diabetic pills are? And then finally, there's a lack of a collective organizing body. And so throughout the country, you're seeing these efforts pop up. And to the extent possible, we do try to leverage lessons learned and share our toolkits. But there isn't one specific body that organizes all this work that would be the go to for questions. There is a Food is Medicine Coalition that is a coalition of organizations that provide medically tailored meals specifically, but that doesn't capture the whole spectrum of where interventions could be, including food vouchers and food pharmacies and mobile food vans. And so went through that really fast, faster than I expected. So hopefully that'll give folks time to ask questions.
Thank you, Rita. That was really helpful and interesting way to outline the programs that are working, and again, especially getting your perspective from it. We definitely are, constantly being challenged about what is. Oh, I'm seeing a small question here. If you could, Rita, do you mind defining medically tailored meals for the audience today?
Yeah, thank you for that question. I think one problem in this body of work is the lack of clear definition. Medically tailored meals is actually one area that has better definition than the others in terms of food vouchers, prescription, and food pharmacy. I was just on a call today where folks were really making a push for we need to just define this and help move this body of work along. So medically tailored meals is in reference to an intervention in which the meals themselves are designed by registered dietitians and very uniquely fit the needs of a specific chronic disease population. For example, for diabetics, there would be a diabetic compliant diet or a renal diet or a heart failure and hypertension or cardiac compliant diet. And that these diets are often tied closely with registered dietitians that design it, but also that registered dietitians are periodically, with varying periodicity, checking in with the patients who are receiving it. So there are specific organizations across the country that define themselves around providing medically tailored meals. If you visit the Food is Medicine Coalition, it lists a number of them across the country that are doing this and coalescing under that coalition. So you can think of it a little bit like Meals on Wheels. Some Meals on Wheels are medically tailored, and the sense I get is most are not. And it has to do with whether or not those diets are specifically tailored for certain chronic diseases. And oftentimes they're delivered.
Right. Great. So if anybody has any questions, feel free to record those. And I do have one question here. Have you included anything, any assistance to mitigate emotional attachment to non-nutrient dense foods, which is so common in our society, like, for instance, with psychosocial issues?
Yeah, so thank you for that question. I will first say that again, part of the part of what drives people to nutrient poor foods that are calorically dense is this natural coping mechanism that happens to anybody in the setting of scarcity. So I do want to emphasize that it's not just due to the individual. I think there's also a lot of environmental and political reasons why it is difficult for certain populations to access high nutrient dense foods, just from an economic perspective, but also just the convenience of going to a grocery store that's near you. Um, there is also a driving force behind being able to offer your kids small little treats, even if they are not healthy for the child, that these are the things that you can provide for your kids that are little creature comforts and treats. And so there's a lot that goes into why it can be difficult for certain populations in certain neighborhoods with certain incomes to be able to eat nutrient dense foods. But going back to the question at hand, one of our food pharmacies actually has a wellness club where patients spend time speaking to a clinician, but also to each other about many of the social stressors that are going on in life. And that has actually spawned a whole movement among our patients wanting to start I forget what they call it. I want to say it's something along the lines of like a social wellness club. It's about it's getting at this sort of the psychosocial emotional health of our patients. And so within our network, we have one clinic that does it, and we have a group of patients who are interested in scaling this further. I do think it's important to address the multiple dimensions that contribute to healthy eating, some of which is personal, individual, and psychosocial that can be sorted through with some counseling, but a lot of it is actually driven by economic and social pressures.
Great. Since we have a few minutes here and we're still waiting if anyone wants to add on any questions, I just wanted to bring up, there was, obviously, you may have read in the New York Times or any publication about this study that came out last week that sort of challenged decades of nutrition advice, basically contradicting guidelines regarding consumption of red meat as it pertains to cardiovascular disease and whatnot. And, just wanted to make a commentary about how added confusion around, the study results and study design is just really furthering to undermine sort of our best recommendations for, nutrition advice from a healthcare perspective. And I guess I just wanted to hear your take on that, Rita, if you have any, sort of insight about the way they're kind of framing it, such that the study design, when you look at large samples like that, you're more likely to get um, that kind of a result, but it doesn't really cross over to smaller sample sizes. Um,
Yeah.
but I also just read something interesting that it's the study was paid for by huge supporters of agribusiness and pharmaceutical companies, which of course no surprise there. But it really does undermine public health recommendations to advance, in the interest of corporate interest, essentially. So I just wanted to hear what you thought about that.
Yeah, I agree with you completely. It was a really unfortunate paper to come out, and um, most of the biggest nutrition experts in the country, and I can't remember what article I was reading, but Walter Willett at Harvard and Chris Gardner at Stanford, Darush Mozafarian I want to say he's at Tufts. So all these like really big names in nutrition science and nutrition research came out um, really opposed to that article. So the article was saying that because studies weren't randomized controlled trials, which are the gold standard of scientific evidence, that therefore you could not make these claims. But the problem is that you would never be able to do RCTs around nutrition because you can't control everybody's diet and then only control one variable, which is the amount of red meat or processed meat that they eat. And so it's a little bit of a cop out to say that just because we can't design this like multi-million-dollar study and make people eat very specific diets, that therefore we can't make statements one way or another about what is healthful versus what is not. And so um, most of the nutrition community stands by what you're saying, Meg, is that no, there clearly is this association. We can't clearly say it's causative, but it's an association between um, red meat, processed meat, and cardiovascular disease, and that it would be unrealistic to wait for the RCT to then definitively say that. And so I agree that it was unfortunate that that study came out to then create some um, confusion amongst the public about what may be health promoting versus not.
Right. And it, certainly undermines all the current research on, not just the personal health effects of eating more plant-based, but also the environmental benefits that can be achieved through that shift. So,
Mhm.
but also, I mean, I guess, this processed meats, red meat and processed meats, both being, held at sort of an equal level, I think is also problematic given what we know about processed meats and salt content and how that relates to cardiovascular health. So
Mhm.
it's all just kind of unfortunate, but
Yes.
there's quite a lot of response happening now to the article, and clearly it just, like I said, undermines public health recommendations for eating more plant based, which seems to be the way forward. Do you have any other questions? I'm wondering.
I
We
see a
actually
question here
have,
about,
yeah,
oh, I just see a question about
yeah.
alternative health community.
Hmm.
So the question is, the alternative health community has linked food and health for decades. Are you collaborating with any of these practitioners in any way to glean their expertise? So yeah, it's a great point. I mean, even outside of alternative health, I think it's also just like the common sense community would say that eating well is important to health, and yet here we are trying to prove that case. I know that there's a new board certification within medicine. I want to say it's like the board of like lifestyle medicine. And so I'm certainly in touch with folks who are sitting on that board and who very much so in support of holistic health. I think we all are sort of working together, certainly philosophically, to push this forward. More closely within San Francisco's collaborative, I don't think we have a strong presence for that. But that's not to say that any of what we're trying to accomplish is in opposition or in contradiction to our colleagues who have much more deep roots in holistic health. Right now, I think a lot of our movement is around how do we convince health systems that this is something they should be doing, and also health payers. So I don't think it matters too much who the message comes from necessarily. And so um, if you happen to know of colleagues in San Francisco who have more of a holistic background who would love to collaborate, I'd be happy to reach out to them. But you're right. Like this has been going on for a long time, and I think it feels a little bit like a turning point or a tipping point in the last, I want to say, 5 years, even that the conversation seems to be really accelerating. And then it sounds like even private food companies are interested in this space as well. So there's a little bit of that I think we're going to start to see in the future as well. Of will it be the nonprofit or the for-profit community that ends up getting payment from health insurers?
Right. And, Barbara just mentioned that, we should be really thinking about, where this conversation should be happening within the nursing community, with RNs and also advanced practice nurses, and as well as nursing education. So that would be definitely a good way to integrate that into our practice.
That's a great point. I mean, a lot of the health system reform I've seen happens because there's internal champions that move an agenda along, and that doesn't have to be an MD. It can certainly be an RN or other staff member who really believes in this, particularly if uh, the nurse has a administrative or clinical leadership role, like a nurse manager. A lot of our work that happens in our clinics are implemented because of our nurse leadership. And for what it's worth, our patients really, really appreciate the on site blood pressure checks and blood glucose checks that they have. There's something about getting that immediate feedback that seems to really um, incentivize and motivate our patients. And in most cases, well, actually, it's split between MD, PharmD, and RNs that serve that role. But there's certainly a role for any and all clinicians to be behind this message that food is medicine.
And then we have a question about how do you locate collaborative efforts in poorer rural areas or even in major cities of 100,000 people population, or Missouri? I'm not sure. More MO.
Um, Thank you for that question. I will admit that I personally don't have that experience working with rural areas, but particularly from an equity perspective and where are there concentrations of poverty and chronic disease, rural areas certainly merit more attention. For what it's worth, we're only able to provide our food services because of a robust partnership with our food bank. And I suspect that maybe in your area that there's probably a food bank as well. It's probably not as concentrated as our food bank network here, but those are some of the beginning ways that you could perhaps be bringing food to your health systems, or just linking up your clinic to CBOs or nonprofits um, that could help your patients access food. The other thing is helping with SNAP enrollment. So, in most places in the country, there's severe under enrollment of SNAP benefits relative to who is actually qualified. So, as much as possible, pushing folks to enroll in SNAP, I think, would be an intervention as well.
Great. So if there are any other questions, we will be happy to answer them. We have a few minutes left. And in the meantime, I'll just mention that our next webinar is scheduled for November 4th, and it's going to be on the contaminants in food and right to know. So we hope you'll join us for that. And if you want to recommend us to your colleagues, that would be great. Also, our previous webinars will be available on the Annie website for download, and there'll be some instructions to take a post-test and get your CE certificate as well. Those are available if you've missed any leading up to today. And so if there's no more questions, one more here.
Oh, wait, here's one. Any thoughts about what people can purchase with SNAP, similar to how WIC functions? So SNAP actually doesn't have the restrictions, uh, doesn't have rigid restrictions on what can be purchased. It has to be food. But it is a bit of a debate whether or not SNAP should be more restrictive to only produce or only healthy items. A lot of anti-poverty advocates say that being poor in America is already so difficult and stigmatized that folks should be able to have the freedom to eat and purchase what they want. And so I hope that gets at your question about what people can purchase with SNAP. And then WIC, of course, is the supplement for women and infants and children. So for pregnant women and for families with kids 0 to 5. I was going to say, if there weren't any more questions, but feel free to ask more questions, is 2 thoughts on food as medicine. One is that one promise and potential of food as medicine is to garner the attention of healthcare systems to engage in this work. But the downside I could see is that it then makes healthy eating seem only accessible through healthcare, which is not the message I would want to send. Healthy eating by certainly can be accessed outside of the healthcare setting. It's more of a rallying cry that healthcare should be doing something around food insecurity and healthy eating. And I actually find that healthy eating is a way to enable patients to own their own health rather than be passive recipients of healthcare from healthcare clinicians. So that is one thing I would want to emphasize, that we shouldn't then monopolize healthy eating and say that you can only get this done if you go through healthcare. It's more the reverse of like getting healthcare to have a stake. And then the second thing I would say is harm reduction. So for really vulnerable populations with limited food options, it's not necessarily practical to tell folks to buy fresh organic produce or use olive oil all the time. And so in those settings, I would think about a harm reduction model and focus more on portion control rather than you know, big jumps in substitution for the types of foods they eat. Also, just making small modifications like opting for grilled rather than fried, and picking healthier options when people are going to fast food, um, or taking measures on such as using canned vegetables or canned beans, but rinsing them off to decrease the sodium content. So these are some of the harm reduction measures that folks can do if they don't have a lot of dispensable income to then make major substitutions in their diet.
Yeah, and I would probably also add some sort of adoption of eating organic. Just because of we're talking about harm reduction, we certainly can't stop there. Well, thank you very much, Dr. Nguyen. We've learned so much, and appreciate your time today. If there are any further questions beyond now, you can be happy to email me, and I will put you in touch with Dr. Nguyen, or it looks like she's given her email right there on the screen. So if that's all, we would conclude today, and we look forward to seeing you at or having you at our next webinar. Thank you, everybody. Have a good day.
Thank you.